Welcome to The Nation. I'm GERARD. Most of us live with some kind of joint or muscle pain, knees, back, neck and shoulders. We're going to be talking about this. Joining me in the studio is Professor Dr. Alice Pratima Michael. She spent a lot of years, over 3 decades to be exacting, in medicine. And she started off with gynecology. And we want to talk about pain. We want to talk about gynecology, where she came from, how she got into aesthetics, and what she's doing now. Doc, it's good to have you back in the studio. It's been quite a while since we had you back in the studio, but it's great to have you here again after such a long time. Now, I've known you for a good 20 years, maybe more. And from where you were, gynecology, you got into aesthetics, and you were one of the first few people to get into aesthetics. And back then, there was a lot of talk that aesthetic doctors don't know what they're doing. But we've come a long way. We've got about at any given day in Damansara Pradana, there's about 5 different aesthetic clinics coming up.
Thank you, GERARD, for the introduction. Okay, I've always been about my patients, right? What they need is what I train myself and do more of it. So when I was doing gynecology in the government hospitals, I also noted that people had a lot of issues which could be prevented. So I started doing preventive medicine. And then with my qualifications there, when I opened my first clinic, which was about 25 years back, and then women were not happy just with good health. They wanted good looks, good skin, better hair, better body shape. Then I went and studied into laser medicine and surgery and a lot of different aspects of cosmetic medicine. And then we integrated that into the well-being practice. And of course, over the last 25 years, and even with the government before, that was 10 years, I have seen that women suffered with a lot of chronic pain issues. Sometimes it's associated with their childbirth, sometimes it's during perimenopause, postmenopause, a lot of aches and pains, and then you find there's weight gain, there's joint issues coming up. And then I felt I was moved to go and study. So I did a course, or it's a fellowship in US, which is sports medicine integrated with wellness. And that is actually talking about how we can improve mobility and movement, and we provide preventive as well as some treatment opportunities where we can prevent people from going into major surgical procedures, and we can help them to live a pain-free life. Because in anti-aging medicine, there's a saying, or in wellness medicine, if you have pain, you're not well. So basically, we wanted to create a pain-free
and if I've learned well from you, if you have pain, you have inflammation.
Yes, that's one of it. But you also have degeneration.
You have degeneration. But having said that, was there a moment or patient that made you see pain differently? You said, this is what I want to do. I need to get into this. This would be a progression from what I'm doing now.
It's a cumulative idea which happened throughout the time I was working as a medical doctor. And of course, as I aged and I went into perimenopause, menopause, I saw all the changes happening to me. But I'm also a very avid exerciser. And I found that, we need to go into, it's not one particular moment, but it's a cumulative effect of all the experiences dealing with pain for different things, And we find that when people age, the pain kind of multiplies. So we find that many people live in pain, and they're taking a lot of pain meds, but they're not actually pain-free. They're dependent on it. So because of that, people feel they can't go for a hike, they can't go participate in a marathon, or some of them can't even sit and do their work. They already have pain. And so I felt like it's important to treat these people from the preventative methods as well.
Right. So I guess, sorry for interjecting, but I guess from what you're saying, I see that progression, but I guess the way you see pain also differs from how other doctors see pain because of your background. How is it shaped? How has it helped shape your approach to treating people who have pain these days?
My mind is always not a disease-modulated mind. My mind is very much towards prevention. So I'm always looking for clues as to when the person is uncomfortable. So if someone starts to have stiffness in joints when they wake up, or they have pain in the feet when they step down, first thing, all this may seem like a minor issue, but to me that is something that is taking away from their well-being. So I need to find ways and means. So I've studied a lot of causes. And of course, I've also done a lot of ultrasound guided interventions into joints over the last 25 years. So that also helped me to study further into not just the joints, but also surrounding tissues, like all your fascia, you have the tendons, you have the ligaments, you have the whole posture, and you have the integration of all the different parts of the body.
Simplify that for us a little bit. So fascia pain and joint pain, what's the difference? Fascia is muscle-related pain or pain on the outside? How would you further make a layperson like me understand that? The difference between that and joint pain.
Yeah, if it's a joint pain, it's just going to be, starts as a creaking joint, for example. You can have clicking or creaking, and then you start to have pain. And we say normally around 50-60% of the cartilage is gone when you start to feel actual pain. So there's precursors to that, so which we know how to manage. And the public also are aware of joint pain. They're aware of terms like rheumatoid, they're aware of arthritis. But when it comes to fascia, fascia is something that is covering the whole musculature, and it's covering across the joints from different groups of muscle. So for example, your fascia from the head, from the scalp, is covering the neck, and then going on to your shoulders, into your arms, and also through the, you have a picture of the thoracolumbar fascia. See how it is covering and connecting muscles. And inside the muscles, there are also minor fascia that covers the muscle bundles.
So I guess what you're saying is there's a lot to understand. It's your work or the doctor's work to make sure everyone gets a simplistic understanding of it, so it's easier for them to work, have a good starting point to start working on the pain they're dealing with at any given point. Now, having said what you've said, you often said, and in the 20 years I've known you, often say people need to listen to their bodies. Of course, I'm still trying to listen. None of my body parts speak to me. But what are some of the signals we tend to ignore as, people in our 40s, especially those of us past 40, right?
Yeah. It starts earlier these days, Gerard, because many of them from young, they are a lot on their handphones, on their devices. And most people prefer to work on jobs that is computer related. So because of the posture of the head, we say you should have the handphone up like this and not down like this, because then you're actually creating a lot of stress on the fascia and the muscles, and then eventually on the joint structures as well.
So if you're saying that people are having problems now, at a younger age, even before in their late 30s or mid 30s, they start having pain, inflammation, joint problems to deal with. Don't you think, and this, I'm juxtaposing this against what doctors or gynecologists are saying these days, that women shouldn't worry about getting their menopause, because it only happens after you're 48, 49, 50. You can get it earlier.
Yes, of course. Women's life expectancy now is 83. So do you expect us to live with a lot of pain and disability and trying to fix what's already broken, which is already gone to you because of the lack of fascial integrity? You find your movements are not good. Your integration is not good.
No, so what I'm asking is that would women get into a menopausal earlier menopause?
It's happening as well.
It's happening as well?
Yeah. We do a lot of preventive women's wellness tests, and we find that from the ages of 35, some women are already impending on perimenopause. And we need to pull them back from that if we wanted to create a healthier population. So many of them are not only degenerated from the ovarian side, which may or may not show as irregular menstruation. That's a different topic. But then it can also affect their thyroid. Many of them are subclinically hypothyroid. They have hypothyroidism. And that may be the reason why they are gaining weight around the lower tummy, the inner thighs. And then the healing is so slow. They may have just gone for a hike. They cannot, after that, recover for 6 months. I have many patients who tell me this. I just went to try this new exercise, and then I sprained my shoulder. From there, I cannot recover. It's because their menopause comes in earlier and they cannot recover from their joint problems as well.
Now, I'd like to go back to pain, and many of us normalize certain types of pain, especially when it comes to aging. At some point, we say, it's not pain, it's just age.
Yes.
Do you believe that?
No, I don't. Because you were asking me an earlier question about earlier signs that people should heed. So that would be things like stiffness. You know, it may be there in the early mornings, it goes away. But if it doesn't go away with a bit of limbering, with a bit of walking around, tingling sensations, a little bit of tingling sensation in your feet or your hands, or a bit of numbness, doesn't affect the lifestyle a lot, but it's already a warning sign that you need to change your posture, you need to work on your movement and mobility, and you maybe need to look at some nutrition that you may be deficient in as well.
Okay, time for you to give us a tip. How can you tell between soreness and a normal soreness of exercising and a real problem with pain that your body is suffering from?
If you have a
Is that a legit question? Is that a valid question?
Yeah, I mean, for those of us who do a lot of different exercises, we know we'll get some muscle soreness, we'll get some muscle tightness. But then it goes away with limbering maybe within a day or so. But if the pain translates, in case you have a quadriceps or hamstring, which is the thigh muscles front and back of the leg, if it is not going away and then it's going down to your knee, for example, then you know it's a more serious pain. Or it's going down and you can't walk properly on your ankles. You can't flex and extend your ankle joints, which is also a common thing I notice among a lot of women. So we find that these are things that if we tackled it much earlier, we just give them what they need and we are able to reverse it. But they need to seek a professional's advice. If they are just popping pills for pain management, then that's not going to be helpful for them.
Welcome to my world. But having said what you've said, I guess the next thing I want to move into, and I'm digressing here, next thing I want to move into is the person watching this program now. You know, it might be an orthopedic surgeon or an orthopedic practitioner, and they're watching me talking to you or watching the show and thinking to themselves, why is an anti-aging person, a doctor who's doing anti-aging coming from gynecology, talking about pain management? How do we...
I call myself a total wellness specialist. I'm concerned in all facets of a person's health. We also dealing with mental pain, you know. We also help people with that, because with the mind-body connection, we know you can get excessively tight due to some reasons, which can be psychological. So we also need to work on that.
Right.
So I think, yes, orthopedic surgeons have a lot of roles to play. And I feel Ministry of Health has done a great job in controlling opiates within this population, so that even private centers, clinics, they're not allowed to have any opiates in them.
Right, right. I mean, just to explain this to the viewer, I guess for those of us who don't know what opioids are, those of us who are going to the small pharmacies and being dished out painkillers all the time, we are the ones she's talking about. Yeah.
Yeah, but this is about opioids. It was a study done in Canada. Okay?
Yeah. What's it telling us here?
It's telling us that
very colorful chart, Doc. Yeah.
people take a lot of opioids on a daily basis. Okay, and some of them, the bigger population, 40% of them are still taking it, maybe once or twice a month. But most of them are going. Other than this, in my understanding, in Malaysia is very controlled, which is very good. But we are still taking NSAIDs. They go to general practitioners sometimes, and they also prescribe steroids. If with NSAIDs, it doesn't go away, the pain.
Right.
So these are things like, again, I call it Band-Aid medication.
Right.
You just put it on top to hide it, so you can proceed with doing. But then the degeneration, the damage is continuing,
So
which is dangerous.
can I simplify this explanation for those of us who don't know what NSAIDs are? We get them from pharmacies all the time. You can buy
clinics.
them. Yeah, or clinics, and brands like, we're not promoting any brands, Celebrex, Corsia, there's a Voltaren. Yeah, there's a whole line of them being sold.
Or even paracetamol, you know, acetaminophen.
Yeah. Are you against paracetamol?
I don't like too much of it. It can lead to Ray's syndrome, which is a liver degeneration.
And how much leads to liver degeneration?
It's a chronic thing. You need to take a lot. But people who are dependent on this, they are not proactive on their joints and their muscle pains or their nerve pains. They are going to turn to one of these things, right?
Right. So when I look at the questions that we've put together, something stands out here. You know, if I'm going to talk about the pains that we deal with on a daily basis, say a knee pain, or spondylosis, or you know, like lower back pain, sometimes there's many different ways it can come about. Sometimes it's referred pain. Okay,
Yes.
so if I'm having a back pain, it might be a muscle in front known as the psoas muscle, which is tight. So if this muscle is tight, it pulls on the back.
Yeah.
So what's the best advice you can give us if we're having lower back pain, neck ache, or knees?
For
And I'm
lower
not talking about myself, yeah.
For lower back is a lot of times it's actually coming from the legs and from the abdominal muscles, you know, the core muscles that support us. So it's not just the rectus abdominis, the six packs. There are people with six packs who come to me with pain like this, but it can be transverse abdominis, which is the deeper layer of muscles, which is not taut or tight, aiding a person. The way we walk may be contributing to it. Being overweight and having more fats in the abdomen pulls the spine into a lumbar lordosis. It also can contribate to that.
What's that mean in English, into a lumbar lordosis?
It's a more curve, you know, the S-curve,
Yeah,
you know,
the S-curve. So
that all the beauty queens have.
Yes.
It's not really good for you.
Right.
You know, and then you cannot
That's not good posture.
It's not a good posture.
So standing very straight isn't the right posture? Is that what you're saying?
It's not standing straight. Your tailbone needs to be tucked down, not up like that.
Right. So
you know?
tailbone needs to be tucked down.
Tucked down, and your muscles in the front has to be engaged.
Right.
And your psoas you talked about is connecting from the thigh to your abdomen to your diaphragm.
Right.
It needs to be tightened as well.
Right.
So when you walk this way, your weight distribution in the load distribution is more on all these structures. It's not on the lower back.
Right.
The other common cause for low back pain is also problems with the front muscles of the hip. We call them the hip flexors. These can also be overly tight. This is very common, especially for professionals like myself, because we are always leaning forward. We are about patience. When we are talking to patients, we are leaning forward. Now you're leaning forward because you want to get a good interview from me.
Right.
So we are leaning forward. When we are doing procedures, we are leaning forward. So when we are doing that, then we are putting a lot of stress. And for women also, hip area is a weak point. If your hip joint is not flexible, then you also develop a lot of lumbar pain as well.
I guess when it comes to pain, there's a lot of things. And there was a time you used to talk about fatigue, chronic fatigue a lot. And I don't want to tie that in because somehow that ties into a person's hemoglobin levels and knowing your hemoglobin levels. But we're not going to be talking about it. What I want to talk about is, I guess the person watching this is like, what is your takeaway with pain? If you have a takeaway with pain, because I'd like to walk into a message about a national campaign that we can dream up today. But let's talk about pain. If I'm dealing with pain now, what do I need to do?
Early diagnosis, that means they go to a medical professional. They need to recognize themselves. They need to know how to listen to their body and take care. And of course, their posture is very important. Correcting the posture can be the first thing someone can do. Doesn't cost any money. And you need to have the forward head posture to be reversed. That means your eyesight may need to be corrected. And you find that this tension is sometimes over-reported as a migraine. Actually, it's not a migraine, it's mostly tension headaches, which transfers to the back portion of your neck and then transfers down to your shoulders. And the thoracic spine plays, which is around the lung and heart, that part of the spine plays a big role in how your head, neck, and shoulder is organized. So a lot of pain that is coming from the shoulder, coming from the neck areas, is coming from the immobility of the thoracic spine. So what happens when the thoracic spine is not moving well? You overwork your lower spine, which is your lumbar spine and sacrum, and you overwork your cervical spine, which is your neck going up to your head. So you start to have a lot of pain. So one of the first things people can do is also breathing exercises. Because when your thoracic spine is very tight, you find you can't breathe well.
So most doctors say we are shallow breathers. What does that mean?
Yeah, we are not opening we may have a lot of tightness around our scapula, around our back portions.
Scapula is around the back here.
Around the back, and it's just on top of your thoracic, spine and the ribs. So that area may be very tight. So because of that, they're not able to expand as in a deep inspiration.
Right.
And then exhalation has to come like a natural mechanism. So you can practice on that to open that up. Okay. So that already helps you a bit. And then, of course, you may have shoulder joint tightness coming from the back as well. A lot of us don't utilize our back to support our arm movements, including me. So sometimes I may get tightness in my shoulder because during my procedures, I may be using a lot on my arm. So you need to integrate your scapula, your spine of the thoracic to your shoulder and your head. So correct postures is very important. Knowing your body and going for a checkup, and you may want to try and find out, this ties a bit to fatigue, but you may want to find out any nutritional imbalances or insufficiencies. So we may need to support with vitamin D. Asian countries with our skin, you know, sometimes we don't get sufficient vitamin D with the activation to the sun. So we may need supplementation of magnesium, vitamin D. There's also capsaicin, which is coming from chili. We can give turmeric. This can just be natural foodstuffs. We eat more.
Right.
Or if you're very deficient, then the doctor is going to suggest you some supplementation, which we need to take. But of course,
so supplementation must be suggested by the doctor and not bought from the pharmacy down the road.
Because for preparing for this, I was just going to find, like, because I know Gerard will question me a lot, so I was trying to find more, you know, stuff on all these vitamins. And I found that every link goes to somebody selling it. So there's no actual literature you can find supports or distracts from what you should take.
Right.
So anything can be too much or too little. So always customizing it to your body needs will still be the best solution. So then we also need to look at it. Other inflammations that can come into play that can make these things worse, like your diabetes, you have some autoimmune. We mentioned thyroid earlier. Your female hormone or male hormone depreciating, all of this can lead to too much of inflammation.
Right.
And that will affect your muscles, your joints, your nerves.
Okay, so I mean, I've got a couple of other questions here which I'd like to ask, but I think let's move into some pop culture for a while, because that's what I like a lot. And most of the time, you know, when you go into, sorry, I'm going to mention TikTok here, it's not a good reference, but when you go into TikTok or you go into social media, everyone's talking about magnesium. There's this magnesium biglycinate, it's good for pain, muscle aches, so on and so forth, and it also helps with sleep. Where do you draw the line with these things?
You can take some supplements, but again, like I said, we need to find out your physiological level, and then we need to balance it out, because if you take too much, it can also become toxic.
Right.
But it cannot replace mobility. Nowadays, we do a lot of active rehabilitation, whether it's a small pain, it's a big surgery.
Right.
We need active rehabilitation.
Okay, here's the other thing. A lot of people are going out and getting injected in their knees, so their blood's drawn and it's sort of processed.
That's a PRP treatment.
A PRP treatment. Okay, can you explain that to us? And does that work? You know,
it does work. There is some healing factors in the PRP. That is, a platelet is having a lot of those things that can help your joint. But most of the time, it's just reduction of inflammation inside the joint. So my thinking is, if you don't overall control the nutritional issues, you don't control your degeneration, what is it coming from? Is it from hormones? Is it from nutrition? Is it just from age? Or is it from wrong movement? Getting people to move appropriately is even more important to me. Because if the joint has degenerated tremendously, a PRP will not be enough.
right.
But if it is early, then we can do the PRP, yes, but we still need to put them through the correct forms of movement. We were talking about fascia and muscle, ligaments and tendons. All of that insert into the knee joint, for example, or bypasses and goes on top, covers it. So if we are not going to work on these joints, we are only putting in for the cartilage inside the knee, how is it going to be helpful? So you need to compound it with proper movements, you know, more movements across the joints, safe mobility exercises. And with mobility, you can get more, you know, strength in that particular joint. And if you don't work on the muscles surrounding the joint, most times the problem will happen again.
Right.
Then you can say the PRP doesn't work, the doctor is not good, but it is not that. It's because the whole program has not been appropriately given to you.
Now, what do you wish patients told their doctors more often, and what do you wish doctors asked their patients more often about pain? And this comes from our producer.
People should say, I'm having this pain, doc. Can you please check it out? Tell me if it is serious or not. So we are doing a lot of preventive health tests pertinent to joints and muscles and nutrition we talked about. So we can find out. And of course, I've trained on ultrasound diagnosis and management of joints, fascia, even things like the ganglion, no, the nerve points, we also can inject. But just by doing the ultrasound diagnosis, we are able to know. And by a proper physical examination, checking on the whole extent of the joints and see how they integrate the movements. Watching a person walk up and down can tell a lot of stories as well.
I don't usually allow people to do this, but I'm going to allow you to do that because you've also been a TV host before. What would be your closing message to all of Malaysia with regards to pain?
Be proactive about pain. Of course, if the pain is killing you, you can do a painkiller, but it should not be taken for more than a week. That's the time for you to find the correct pain doctor. Okay? Find the correct pain doctor, go to them, let them diagnose you, and do exactly as they say. We do a lot of treatments into the joints, muscles, fascia, nerves. Most of the time people follow all the treatments, but then they don't come in for their movement exercises. When we teach them, I ask them, show me how you did your exercises after the, the joint injections, and they will do something that is exactly not correct. That means they forgot, or they did the wrong thing, or they completely did not do the exercises. So it's very important to be compliant with the exercises as well. And if you're a regular exerciser doing a lot of daily workouts like what I do, then you also need somewhere where you need maybe infrared sauna kind of treatment to heat up, improve blood circulation, help to reduce all the inflammation. You may need a cold plunge or a cryotherapy chamber which can help you to recover from the inflammation of exercise. Of course, you may need specialized nutrition as well.
Right, so if that sounded like German for you, cryotherapy, so on and so forth, we'll definitely have a part 2 on this. We'd like to thank Professor Dr. Alice Pratima Michael. If you had a name tag, it'd be this long. For some eye-opening insights and why so many of us are still living in pain. Thank you very much for joining us on the program. We'll be giving you more updates right here on Bernama TV via our news bulletins coming up shortly. This has been The Nation on Bernama TV. I'm Gerard Ratnam signing out. We'd like to thank Dr. Alice Pratima Michael, or to be exacting, Professor Dr. Alice Pratima Michael.
Thank you, Gerard.
Thank you very much. Thank you.
Mulut jauh hari menjadi taruhan, menebar kata berselimut sakti.
Arif tak bolehlah putus asa.
Ni kan budaya kita.
Arif anak ibu. Yang penting ni, ibu ni peminat nombor 1 Arif. Jadi Arif kena terus berpantun.
Hari ini saya bersama dengan seorang adik yang comel. Macam mana adik Arif suka dengan pantun?
Saya nak kekalkan yang sedia ada. Budaya kita, cara kita.